So it's great to be here today. So many smart people in this room. This is a good investment of time for all of us, I hope. So I'm going to talk about what Kathy and Annette told me to talk about, of course. Just want to clarify that from the very beginning. But I'll tell our story at Encompass. So our organizational overview first. So today, Encompass operates out of about 154 locations in 18 states. We do home care, hospice, and we do a little bit of pediatrics. We have about 5,600 employees, all of whom struggle to understand what a certification is in home health. We've won about 30 Best Place to Work awards since 2013, and we really try to be a best place to work, and part of that is educating your staff and keeping them informed. And so when Oasis Q&As come out, we inform our staff. When the changes come out to face-to-face, we inform our staff. They have all received a copy or a link to CR 9189, which has been very exciting as well. Our turnover remains low, and we hope that's partially because we engage and educate everybody and treat them like they're professionals. Annually, we do about 2.5 million patient visits, and we're currently serving a little bit more than 75,000 patients across our 18 states. So now our technology platform, and I guess I'll tell you a little bit about me too before I do technology. So I've been with Encompass for about 7 years. I'm a physical therapist by trade, and started with the company in a sales role actually, and then moved into the operations side, and then became chief clinical officer about 3 years ago. Somehow face-to-face fell to me. I think I just didn't dodge it as well as some of the others in our organization. But it kind of fell into my lap. So medical review reports into me, as well as clinical services, etc. So that's kind of how I landed here. To know about us, you've got to know about our platform, our technology platform. And I think there are some other home care, home-based users in the room. Can you raise your hand if you're on HCHB? Okay. So very good. So there's a bunch of you guys who are familiar with our technology. But HCHB, we developed it at Encompass about 12, a little bit more than that, years ago now. Web-based software platform that offers point-of-care technology. And so when I started talking to Harry and Annette and Kathy about process, when they said they wanted to come in and talk to us about process, if I'm being really honest, I kind of had a little bit of an attitude of, we've got process. What we need is for you to understand what's happening with us. Processes, we've got nailed. You ever heard of Home Care Homebase? We've got processes. And so you'll see that, of course, I was in error. So I won't go too much more into Home Care Homebase, but it does offer a workflow-based system. So when something comes into the system that requires execution, workflow is triggered onto somebody else's computer screen, and so it's really an accountability mechanism that works quite nicely. And we did have face-to-face functionality inside Home Care Homebase, and we've been working with Home Care Homebase and several other customers to update that functionality as the rules change over time. So a little overview here about how Home Care Homebase really drives our company from a clinical standpoint. All of our documentation goes in there. From a sales standpoint, it's also our sales engine, and so the sales teams utilize Home Care Homebase or an app through Home Care Homebase to manage their sales processes. Management and operations, so everybody has full transparency from the leadership side to be able to see into what's happening in the system, and then it helps us to drive compliance because it's really a check this box tool. So was face-to-face reviewed? Yes or no? Check this box, tell me what status it's in. So we really felt like we had a comprehensive approach to reviewing certifications, to reviewing face-to-face, and to making sure we were compliant and doing well, but we still struggled with these denials. So there's a great book out there called Start With Why. So I try to bring this up in every presentation I do. So I really have to talk about the why we're here. We were struggling with denials for face-to-face. I'm sure, unlike all of you, this was purely an Encompass issue. In a few providers specifically, we had a very high rate of denial related to face-to-face, and my medical review team came to me and were screaming. This was denied, and it was the best face-to-face I've seen in weeks. And I said, well, send it to me and let me look at it and understand what's going on. And so they sent me several of these face-to-face forms and examples of face-to-face documentation that was denied, and I thought, gosh, this is better than a lot of the stuff I see out there. And I really don't understand. This looks like to me it hits all the key criteria. And so we reached out to the provider call center and tried to talk to somebody here at Palmetto about what's going on. So how many of you called the PCC? All right, so it's no different anywhere else. I'm not here to beat up on Palmetto. I love Palmetto, and I'm going to talk about that a lot. But we were struggling to find somebody at the PCC who could really explain to us what was wrong with these certifications. And about the same time, a little bit before this, we were at a conference where there was a representative there from one of the other MACs. And it's the worst thing you can do to go to a home health care conference and bring up face-to-face. And so one of the representatives from one of the MACs was talking about face-to-face and said, we just need to see a little more. We need to see a little more documentation. And so somebody at this conference, God bless her, pulled out a denial and an example and ran up to the stage and said, "What's wrong with this?" And he looked at it, and he paused, and he said, it just needs a little more. and everyone in the crowd, I really thought there was going to be a stage rushing, and the frustration levels were so high, and I felt like I was back in that same scenario with it just needs a little more. And so we thought we had to jump over this bar, and we jumped over it, and it wasn't quite good enough, and so the bar was raised a little higher, and we're jumping over that, and then somebody to tell us it just needs a little more. Felt like somebody was saying, jump over this bar, but nobody knew where that was. And so we respectfully disagreed with these denials, and we were seeking relief. We were seeking a way to have this due process work out without going through all of the time it now takes to go through the appeals process. And so I had the great pleasure of meeting Dr. Feliciano previously. We're both huge fans of the ICF, International Classification of Functioning Documentation. And so I heard him speak at a conference in Chicago a few years ago, and that changed how our company does documentation. So at Encompass, we're all in with ICF. It's in all of our forms. And so I reached out to him on his telephone, called his office, couldn't get him. Very difficult to reach guy, very busy guy. And I took a chance as Kelly Shearer, our director of billing, and we were sitting in Kelly's office, and I was frustrated because I get to explain to our board and to the rest of the executive team why our denial rates were increasing. And so I took a chance, and I knew Dr. Feliciano was on Twitter, so I tweeted him. And he replied. And I said something to the effect of, getting a lot of denials, can't explain them, I'm drowning, save me. And he offered this opportunity to participate in this process. And I didn't fully understand it, so we had a couple phone calls, and we negotiated on how we would work through this process together. I'm apparently a terrible negotiator. But in the end, it worked out good for us, and so we sought relief that way, and we were encouraged to see a hand reached out back to us that we hadn't seen before. And so that's kind of how our story begins, is incredible frustration, reaching out through the avenues that we knew, and then taking a chance. So I'll also stop here and say, if you have a Twitter account and you don't follow Dr. Feliciano, don't listen to me. Just go ahead and log into Twitter and go follow him real quick. He puts some great stuff on Twitter. So then this question came up: why would anybody engage with a Mac? They're scary, right? Their sole purpose in life is to deny claims and make our life miserable, right? So when I took this back to our organization, to the executive team, and I said, here's what we're going to do. We have an opportunity to really work closely with Palmetto GBA, and they're going to come into our offices and sit down with us and get to know us and look at our records and look at our processes. And a lot of the members of the executive team looked at me and said, why would we do that? Exactly. And we said, well, because one, there's no really good alternative, and two, what an opportunity. It may be a little scary to get really close to max, but let's try it and see what happens. It can't be any worse than denials for face-to-face, because right now, getting a denial and then getting a letter explaining it, just copying what the rule says, doesn't really help. So they've offered to come in. Let's at least talk to them. And so we had several conversations, again, where I tried to negotiate poorly. And I found out that Harry and Annette and even Kathy were kind and generous human beings. And so they really put a face on the process and convinced us that they were here to help. And when I heard Dr. Feliciano say repeatedly, Palmetto GBA exists to pay claims well and to work with providers, not just to deny claims, got me excited about the opportunity for a collaboration. And so there's a quote here. If CMS wants to reduce denial rates, work with us, like Palmetto GBA. Don't just deny claims and send me a letter. Now, that's from an anonymous source. But I think that's really kind of the thesis of what I really wanted to say today to CMS if they were here. So, our team members. So here are the members of our team, much like the others. We tried to involve folks out of every single org chart in the company. So I was there. Our Director of Medicare Billing Services, Kelly Shear, who couldn't be here today, he had a medical problem and wasn't able to attend, so I'm representing him by proxy. Our regional vice presidents of operations, our agency administrators were involved, branch directors, directors of nursing, our medical review team. So we have a team of nurses who help us with medical review to appropriately aggregate the record, organize it, and then review it and write a cover letter using ICF language to explain medical necessity, homebound status, what went on, what happened, and why, in a nice cover letter. So they came. Our sales teams came, which got interesting. The medical records staff came, and then we had some field staff and some clinicians. And almost without exception, everyone who came in was very quiet initially and didn't know what they could and couldn't say in front of this group because they were just nervous that they were going to say something and Dr. Feliciano was going to say, aha, now we're coming in, we're looking at the whole organization. So there was a lot of anxiety, but they really did an excellent job, and I really got to say kudos to you guys at relaxing all of us who, frankly, have just learned to be skeptical. Barriers. Man, were there barriers. Encompass knowledge deficits. So we thought we knew, but we didn't know what we didn't know, and we saw that continue throughout the entire process. And we work hard at understanding this. I mean, everybody reads these releases, everybody reads these rules, everybody reads change requests. And we attended all of the webinars, including the home health clinical template webinars. You guys enjoy those open door forums? So maybe we could talk about those later. Maybe around happy hour. But we all, we listened to all of those, and we thought we understood something, and then we would hear somebody else, a supposed expert, maybe on an open door forum call, say something that completely changed our perspective. And so it was good to work through this process and learn. We encountered physician knowledge deficits, and I think we've already talked about this a great deal, but I thought the question earlier and I'm looking at you, yes, I thought your question was fantastic. Like, this has been happening for years, and where has CMS been in educating physicians, the folks who own this plan of care, who own the process, who are responsible now, even at risk for their E&M billing? Where have they been in educating the physicians? And I think our point, and probably the point of everyone in this room, is when there's a void of information, somebody's going to step in and try to fill it. And who knows what information they're sharing. So it was interesting, and I actually enjoyed going to the physician visits with our group to hear the physicians' take on it. And, and their level of understanding. And the people in their office, it was eye-opening to us. And then home health community misinformation. So, oh my gosh, what we definitely found is that when physicians don't know the answer and somebody else is bringing the answer in, like another home health agency, man, there's so much variability there. It ruins the process. And so I don't know that you all had this experience, but I'll just be honest about our experience in a lot of markets. As soon as the 2015 final rule went into play, agencies were telling physicians face-to-face is over. Don't worry about it, which we had to go back and undo. Prior to 2015, we had agencies who were willfully, that we were competing with, willfully and openly completing the face-to-face documentation for the physicians. And so we repeatedly had physicians who would say to us, well, agency X, Y, and Z fill this out for me, and it's really good. So why don't you just fill it out? And we would explain why that was not allowed as part of the process. And so we would point them back to the MLN articles. We would point them back to the Medicare Benefit Policy Manual. But anything more than a paragraph, they don't have time to read. And so when there's a void, people will step in to fill it. And so we need to make sure there's not a void when it comes to really complex understanding of rules and regs like this. Lack of an effective tracking mechanism was a major barrier with us, because one of the first things that the ladies asked us in our meeting was, what percentage of your referrals come in with a complete face-to-face? And I said, because I love to jump in and give answers, I said it's at least 50%. The medical records specialist to my left at our Dallas location said it's closer to 0%, which started a long series of me being wrong and everybody else in the room being right. So I'm going to talk a little bit today about our tracking mechanisms, not so much for the face-to-face piece, 'cause I think others are doing that, but for billing. And so we can understand the process as a sort of lag measure. Lack of internal controls and insight was another major barrier. Redundancy, like many of the others who've already been up on the stage and talked about everybody's chasing the same thing, it got so desperate with the prior to 2015 rule that we really intentionally, in some cases, just said, we don't care who's going after it, just whoever can get it, good for you. And so we had numerous people in the agency who were going after the information, and so we had to stop and redefine whose responsibility it is, because ultimately we found that we had crowd effect. And so as part of the process, I did a little quick poll of a few agencies and just reached out and said to the branch director, who's responsible for tracking down face-to-face in your agency? And she said, sales. And I said, okay, great. Who in sales? And she said, all of them. And I said, okay. And what if they don't get it? Well, what do you mean? Well, when does it become your responsibility as the director of nursing / branch director for this agency? Oh, honey, it's not my responsibility. That's sales, right? Okay, next phone call. And I got different answers because we'd never defined it. So redundancy was a major barrier for us. Waste was a major barrier for us. And every time as we were mapping out the process, whenever a pink sticky would go onto the map, I felt personally offended. And so if you'll look at my slideshow over here in a little bit, you'll see there's one particular picture where I was out of town and I couldn't control the process, and so they put sticky after sticky after sticky up there just to mess with me. And then a barrier that I didn't list here that came up often in the process, and so I'm just curious, because I think there's always this tension between operations, clinical, and sales. But something else that came up in our meeting very early on from the operations people, from my people, when they asked about barriers, was sales is a barrier. And so I said, wait a minute, don't put that up on the map. What do you mean sales is a barrier? They're on your team. And there was quite a bit of finger pointing that came out in our process, where people were talking about problems they were having with other members of the team instead of the process itself. And so we had to address that early on by saying, you can't put somebody's name up here on a pink sticker. As much as we would want to, And I don't think any Bud stickers made it up on the board. I did have a pink sticker attached to me at one point indicating that I was being a barrier. So our initiatives list was, like the others, was very exhaustive. So we've listed a few here, and I thought I'd just review them for the group. We determined that we needed to educate physicians because there was, again, that void. And so we created a physician education letter. That letter contained the briefest possible guidance that we could put in that letter form, explaining what the rule was about, how it was written at that time. Then we also provided education in that same letter on the 4 questions from Dr. Feliciano's video. And ICF language is very familiar to us. We took this as an opportunity to go out and train our physicians. So we put those 4 questions in the letter as well, and then we sourced it. And we tried to make very, very clear that this is not the opinion of Encompass Home Health. There were no opinions expressed, just these are the facts, this is what the rule says. If you have questions, let us know. So we wrote that education letter. I can tell you we will be rewriting that letter. We've already rewritten that letter again, and hopefully we'll get it right. A revised fax cover sheet and referral form. So we definitely figured out that the information we had coming into the system was not comprehensive enough. It was not complete enough. And we found that we had actually traded off referral source ease of use for having more comprehensive information coming in. And so we went back in collaboration with the sales team, redesigned the referral forms, and have been using those very nicely ever since. We decided we needed an SOP for a referral failure. And I trademarked that term, so you guys can't use that. But we needed a process for what do we do with the referral. I think somebody mentioned earlier there was a question about what if you don't have a physician to follow. We had processes for that. We know what we do in that instance, but we didn't have an SOP for what do we do when we don't get adequate information at intake, which we dubbed a referral failure. So what if information doesn't come through from the hospital that contains sufficient information to support the face-to-face? What if we don't get a medication list? We didn't have an SOP to identify, do this if this happens. And so this made us really think about how we treated referral failures, because we kept thinking and finding out that the more we looked at the process, we go back to the beginning and there's a void of information at the beginning. We had to make sure that we had a zip code lookup tool so that if a referral came into one of our offices in the DFW area, that it got sent to the appropriate office. We saw that created problems. Internal education was huge, and so we put together an internal training tool for our staff. We decided we had to drive utilization of our portal. We have a portal that allows physicians to send in referrals, to produce face-to-face documentation, and that we had better documentation when physicians use that portal. And so we kicked off a big initiative inside of our sales team to increase utilization of our own portal. We definitely wanted software enhancements, and so us, like other customers, have been working with Homebase to enhance the software. And then we addressed who owned that process, face-to-face process. So we identified a process where when a referral comes in, it is a responsibility of the area manager to make sure that we had all the information we needed for a complete referral, area manager being the sales individual, that we had all the information necessary for a complete referral. They had 14 days. We gave them a timeline. You've got 14 days to get all this information. After that, you're out. And it moves on. So after 14 days, that responsibility went to the branch director, because we discovered that we had sales team members who were telling our clinical staff and intake staff, don't call my doctor. He doesn't like it when you call. She doesn't like it when you call. Go through me. We actually found that to be quite common in these areas where we were having trouble, in the branches where we were having some trouble. And so we defined it with sales leadership. We said, we'll give you 14 days to track this down. After that, you're out. And the clinical folks step in, and they have full rights to do whatever they need to do to get this full information.
How did you base the sales compensation if they didn't get it done in 14 days?
That's a great question. Today, that impacts their annual review whenever they have their performance reviews. It does not. We do not have that information or that linked to their compensation directly. I can tell you that there are a lot of people who would like to say they don't get credit for a referral until all the requirements are met. We haven't taken that step yet. But I know a lot of companies who have, and we're watching them closely. Have you done that?
Well, I'm with the state association.
Okay.
I knew that would be a question.
Yeah, I think that's a question a lot of us have. We haven't gone down that road yet, but I can tell you that the more and more friends that I talk to in the industry are telling the sales teams, you don't get credit for anything until all the requirements are met and we can drop a bill. And then the last initiative really came from our billing group. So they said if we're going to track billing information and if we're going to try to hold people accountable, we've got to have weekly stand-up meetings. And so Kelly Shear kicked this off as an initiative, and it's really paid some dividends. So we'll talk some more about that. Primary challenge is we wanted to create a solution that was reproducible company-wide. We really didn't want one-off processes happening at our locations. And so that took a little bit more work, and we're still, frankly, trying to get there. Setting goals. We had to identify our current performance, which meant we had to develop metrics, interim goals, and target goals, and then finally developing and implementing measures. And this is really where Kelly and the billing team helped us out greatly. And we'll kind of go through this the next several slides. But we had to ask ourselves, what do we need to measure? What are we capable of measuring? And what resources are needed to measure? And that really was born out of Annette saying, what do you measure? Well, how do you measure it? Well, what's your goal? And it was on a particular day, they trade off good cop and bad cop. And this was on a day where Annette had taken the bad cop role and was just, I was almost weeping. But we worked through it. So here's some examples of our measures that we tracked and some of the outcomes. So we, overall, in the providers that we were targeting here, we saw a 47% reduction in total unbilled episodes. So that was a significant move forward for us. 2014 start of cares that occurred in 2014, face-to-face was responsible for about 25%, a little more than 25% of the total unbilled. In 2015, after these processes had kicked in, face-to-face was responsible for less than 10% of the total unbilled. And so we were moving that down the list as a problem, and then we chased new problems later on. So we looked at measures unbilled by category. And so the categories that we broke down to measure how we were doing were broadly internal problems, like have we locked the OASIS? Have we submitted the OASIS? Is it holding up internally in some workflow somewhere? Face-to-face and orders. And so measures that were looked at these stand-up meetings were total claims held for the provider. They try to move these claims forward week by week. So they would look at last week's meeting notes and who they were focusing on. And before they talked about new problems, they'd say, did we address all the problems that we discussed last week or not? So we'd look at the last week, and then they would look at claims that were likely headed toward being more than 90 days old. Then they would drill down into claims held details. And so we were trying to figure out specifically what is the problem inside these categories. And so you see some examples here of some of the claims held details that Kelly had built into these reports that we could look at branch by branch. Days to bill wrap was measured and trended, with an interim goal being 4 days and a target being 3 days ultimately. Average number of days between the start of the episode and when these following requirements were met is how this was defined. And so we looked at this and we tracked this. We continue to track this. We're moving toward that interim goal, and that target goal looks great, but we're not there yet. Days to bill final claim. Interim goal is 21 days. Our target goal, we'd love to get this down to 14 days. Then you see the definition there. But what we found is that these stand-up meetings for the locations where we started piloting this process just greatly accelerated the claim moving through the process, because what we found is we knew we had problems, we knew we had claims being held, and there was no clear message about who was working on them and who was doing what. So the stand-up meetings that Kelly kicked off had a significant impact on us. And then we were tracking days to get orders signed. So Face-to-face was our most significant billing issue, and now that we've kind of worked through this new process and we've done better there, now it's transitioned over to days to get orders signed being our new biggest issue. Additional measures that Kelly was tracking as part of the billing group was greater than 90-day AR. And so he analyzed claims by the claims held category, setting thresholds, focusing on locations that were outside that threshold. And in the providers that we were really drilling down on here, 80% of those are now within an acceptable range in terms of the percent of AR that's greater than 90 days old. We saw a 37% improvement there, which is fantastic. So lessons learned and process benefits. What I would really want CMS to hear, if they were here, and really want to say thank you to Palmetto for being here. What I really want to say is that first box, that collaboration beats castigation any time. So by working with us, we learned so much more in this few months than we've learned from all the MLNs and all the CRs and all the conferences before. Collaboration wins. We learned that the real enemies are misunderstanding, redundancy, and waste. Definitely. And again, I came into the process pretty prideful about our processes and thinking that there was not a lot of opportunity there, and I was horribly wrong. People are not the problem, that processes are the problem. And in all of our meetings, people kept coming up, but they were never really the problem. It was the process underneath that was really the issue. Metrics and measurement are crucial. So we learned that we had to define it, and again, at Annette's pestering, that we had to define it, we had to be able to measure it, and that was a huge piece. The next thing we learned is that leaders must lead. So it was very, very important for us to have not only me and Kelly at those meetings, but to have our regional and local leaders at those meetings. And they really took the ball from there. And we encouraged them to make sure that we were following up on the initiatives and to make sure that they owned that process from start to beginning. And so we definitely learned that leaders must lead and that we have to have a common goal. So it was exciting to actually share a goal with this group and with Palmetto to say we want to improve the percentage of claims that go through first pass and that don't come back to us denied. We want to improve our accuracy here and lower the percentage of claims that are denied. The benefit of the process is greater understanding of how to correct those problems that lead to inadequate documentation or incomplete certification. So to sum it all up, we learned a lot through this process and were greatly rewarded, and we're still reaping those rewards from the process. Supply chain messages. All parts of the healthcare supply chain are interdependent, and man, that's moving forward definitely. And so as we move into value-based healthcare, that interdependency is going to be more clear than ever. But this was a great discussion with the physicians to say everything that you do impacts us, and oh, by the way, our claims impact you now that CMS is proposing to review your claims if you have a high percentage of denials. So everything's interdependent. We all have to work together, and I think this was a great opportunity to highlight that. Providers within the healthcare supply chain are desperate. My words. I think we're desperate for the following. We need clarity, consistency, collaboration, and our goal for all of us is conservation of the Medicare benefit. None of us like to read that 50% of claims were denied for home health review. None of us like to read. That's embarrassing to me. None of us like to read that. None of us like to read about all the fraud. None of us like to read all the negative headlines that home health is getting. And through processes like this, I really believe we could reverse that. And I think we could identify the processes and the problems that are contributing to that. So those are our supply chain messages that came from our experience. Now, I do have an update. We looked at, one of our measures that we were looking at was the percentage of time we got physician visit notes, that face-to-face visit note. So when the rule came out and was finalized, we began asking physicians, give me that note. You said the date happened, the date of the encounter was here, give that note to me, send it to me. We had our sales team chasing it for 14 days. After that, it turned over to the branch director. So we've been pursuing these face-to-face visit notes from the physicians with reckless abandon. And we found that we got those notes or supporting documentation from the hospital, the discharge summary that would substantiate the face-to-face encounter about half the time. I don't know what you guys are experiencing. We're an independent, so we don't have any relationships with hospitals where we're collaborating, no joint ventures. That's not something that we do. But we found that we were receiving these notes about 50% of the time, and then as we started reviewing them to make sure they said what they needed to say, in many cases they did, but in some they didn't. And so we've had to go back and look at our review process of these notes that come in, because the word that scares me in the rule is corroboration, that the physician documentation must corroborate what our documentation says. So we didn't feel like this was acceptable 50% of the time, and so we determined that to be unacceptable for our standards, and we've updated our process, especially after we read CR 9189 and I regained consciousness. So I read CR 9189 and started thinking about the probe and educate, which just sounds bad. I mean, the PR group at CMS could do something better than probe and educate. But as we read CR 9189, we passed it around the organization, and we started thinking about the probe and educate process coming with claims beginning August 1st. We realized that we needed to be a little bit more aggressive, and so we're updating our new process with a secondary form that we'll push to physicians that highlights what's going on with the patients. We're going to send that to certifying physicians 100% of the time. We're going to work with them to educate them on what it means to incorporate something into their documentation, because we found the same, that when we would send something to a physician, if it came from one of our agencies, they didn't care. They don't keep it. I was hoping, like, you've got a secret Encompass file, right, where you keep everything. You created something in your software. And so we have a lot of education to do there. I think CMS has a lot of education to do there for physicians. But we're going to send that to physicians 100% of the time, and we're still seeking some clarification on some of the aspects of documenting this face-to-face encounter, who can sign, what has to be signed, etc. So that's our update, is that overall the process greatly helped our billing process. It greatly helped our compliance with the regulation. It greatly helped our understanding of what was expected. And I think it greatly helped the physicians and the other groups that we met with to better understand what this whole healthcare supply chain thing is and how we all are interdependent on each other. So that's my story. I think I'm on time, and I have some time for questions if anybody is still awake.